Good, I've got no conflicts. I'm publicly funded. Right, so we're going to talk about AF and heart failure, but of course you've heard of most of that. But I think it's worth saying that Eugene was very prophetic when he said in the last millennium that these two would become the emerging epidemics, and indeed they have. But I think what we've seen more recently, and this is replicated in numerous data sets, is that we may have seen the peak, at least of the incidence of heart failure. And certainly through multiple cohorts, we now see that mortality is coming down in heart failure patients quite consistently. But of course, that doesn't necessarily reflect what's on the ground. And this is a nice graph from US hospitals about what's happening to the change in the nature of heart failure. So although we're seeing perhaps a reduction in patients with reduced ejection fraction being admitted to hospital, there's a consequent rise in those with HFpEF. And of course, that is a particular group that's of an issue with an AF audience because of the multimorbidity associated with it. However, things for AF are, of course, very different as we're all used to seeing. So incidence in AF patients is actually increasing in older patients. And that's a particular problem because, of course, the population is aging. But that has a consequence on prevalence. So this graph just looks at what the UK is predicted to change in population over the next few decades. And if you use that incidence data, you can model what happens with AF, and you get lines like this. And that's been repeated for German and Icelandic cohorts and others. And essentially, we're looking at a near exponential rise in those with AF. But of course, the big problem that we face is that we haven't really tackled mortality in the group of patients that is the most likely to have AF, the older population, those over 75. We're doing quite well in those who are younger, and that's a great attribution to all of you guys and your teams. But it's in the older patients, particularly those with heart failure, that we haven't really had as much impact as perhaps we could. And of course, we all know the shared causalities between AF and heart failure, and René went into some of the biomarker parallels between them. So we don't need to go into that. But I think the epidemiology of the combined nature is probably worth reconsidering. I think most of us are quite happy that it's about a third. But actually, more recent data, and this is the stuff from Framingham, suggests that perhaps that's quite an overestimate. They looked at patients who had new AF or new heart failure, and actually you see that 60% of the patients have combined disease. And really the bit that we're missing that we often don't think about is those that have the condition after the incident, whether that's AF or heart failure. So if heart failure is such a greatly important part of AF management, why don't we use it more as a stratifier beyond actually the very basic things that you've already heard about, categorizing things very crudely? Well, of course, the predominant reason is that heart failure itself is a heterogeneous condition, just like we've heard that AF is. And so you've got two effectively syndromic conditions, and that's very difficult to pin down in pathophysiology. So both of these patients have AF and heart failure, and we're used to seeing them in clinical practice. The one on your left has a thick ventricle, small cavity size, filling problems, but they have the same symptoms as the patient on the right who's got a dilated cardiomyopathy and in fact came in with a ischemic infarct. So that's the real issue around these two conditions combining. And the other part, which probably we don't think about too much in clinical practice and certainly in studies, is that the nature of our measurements changes, and we have to remember that the validity of the things that we use, like cardiac imaging, are affected by the irregularity that we see in AF. So it shouldn't perhaps surprise us that when we see ablation studies and they have a really marked improvement in ejection fraction, is that true, or is it just the way that, for example, we're measuring and using these values? So if you're here on Tuesday, one of my PhD students will present some of this data, but she's very painstakingly looked at thousands and thousands of beats in patients with AF in 100 patients. And actually, even with that one person who's very experienced, the range of reproducibility is quite marked. So are these actual variables valid? Probably not. We need to really think about how we use them in patients who have both AF and heart failure. Incidentally, and I'm not going to go into this, you can actually improve the reproducibility profoundly just by thinking about the physiology in AF and using better measurements. So those are some of the issues, but where are the opportunities? Where can we move on with health data in patients with AF heart failure? Well, one avenue, as you've already heard from the previous talks, is thinking about using big data. Now, that can be not only looking at genomics, where you might have a small number of people, but with a large volume of data, but also the other extreme, so electronic health records, where you have millions of patients, and you can look more on a population level. And so all of these processes are in work, and one of the key things they use, of course, is machine learning, artificial intelligence, to try to understand and put in what are basically standard statistics, but to use them on more complicated data. So do they work? Well, this is a SWEDHF registry study for heart failure. They used machine learning, and they identified 4 very simple clusters that were associated with 1-year mortality. And you may say, okay, well, that's just common knowledge. Why is it important? Well, actually, if you look at those clusters on the top, they quite nicely delineate patients with heart failure in terms of their prognosis. And in fact, they do it much better than standard things like ejection fraction. So there are some values to some of these techniques. What about for defining the onset of the condition in the first place? Well, this is a large US study where, again, they used machine learning techniques to look at the temporal relationships of heart failure. They used variables within a 12 to 18-month window observation, and then they predicted whether patients would have heart failure in the following 6 months. And they actually did fairly well. So these are the C statistics here, and you see 0.7, 0.75, so probably better than most stroke or bleeding risk scores that we've seen. I've put the full data here because I wanted to make another point, which is that there's a whole list of different types of machine learning algorithms that can be used. And of course, part of the challenge with anything that's coming new is to define what works in what populations. And that, of course, is still a big evidence gap for this part of the method. So can we use that in AF and heart failure? Well, I've shown this before, but this is the double-blind randomized trial data from the beta blocker versus placebo trials, and we saw very clear benefit from beta blockers in HFrEF patients with sinus rhythm, but in those who had AF on an ECG at randomization, there didn't appear to be any mortality benefit. But let's dissect that a bit with some of these new techniques. And in the interest of time, I just want you to concentrate here on this cluster 5, which is a very interesting cluster. So these are predominantly resistant hypertension patients, but actually in the sinus rhythm group, that cluster has no benefit from beta blockers, whereas we see some inkling of benefit in those who've got AF. So some of these clusters and some of these machine learning algorithms can give us new concepts that we can take forward to trial further medical therapies on. There's also an opportunity for some of these new techniques to give us better assessment. That might be outcomes, it might be patient outcomes, etc. One thing that we particularly do a lot of is use heart rate in our clinical practice. And again, this is some data we've already shown that in sinus rhythm with heart failure, there's a very clear linear association between heart rate and prognosis, but we don't see that in patients who have atrial fibrillation. And that may, of course, partly explain Isabel's very elegant RACE2 study where she randomized permanent AF patients to strict or lenient control and found no real difference in terms of composite clinical outcomes. So that's a challenge for us, and we all know that heart rate is a very fickle measurement to use. So can we do something better? So in a trial setting, we're using combinations of active and passive monitoring using accelerometers, which give you very high definition information on patients' motions and their movements, as well as using wrist devices and so on to measure heart rate, not just at focal periods, but across the circadian time rhythm of the patient. And we can use these techniques to start to get a little more insight into what's actually happening at a patient level. So I just show you 2 patients here. The one on the left has a very high baseline heart rate. You see quite a high level, relatively low fluctuations in respect to their physical activity, which you see in orange. In contrast, this patient on the right has a much lower baseline heart rate. You can see that overnight time in particular, but has quite marked and varied fluctuations. And in fact, develops quite sustained tachycardia even well after physical activity stops. So can we start to use these techniques to really have more precision approaches to our patients, individualize how we manage them? Of course, limitations are huge here, and we have to bear that in mind. In the next study we're doing on wearables, we'll collect 100 megabytes per patient per day. So if you have terabytes of information, what do you do with it? It's all about redundancy, it's about noise, and we need to develop new techniques to manage that degree of data and also then to validate them. But of course, there are huge benefits to that. We can start to subphenotype these patients. We can start to look at different data types. We can start to imply the effectiveness of therapy based on individual insights. And so these are sort of potential targets that heart failure and outcomes will present for our AF patients. Thank you.